Hi guys, so today has been interesting. No spontaneous vaginal birth, but I did have a forceps birth, and let me tell you about how that all went. I didn't expect it, but the midwife, like once you've done this for a while, you kind of have the inkling. So she thought that we might actually have a cesarean section from the beginning of the shift. So this lady, it was going to be her second baby, because it was her second pregnancy and she has a baby at home. But in her first pregnancy, it was actually a forceps birth, and she had over 2 liters of blood loss, and it was quite traumatic. The blood loss was due to the tone of the uterus, so the uterus did not contract well afterwards, contract back into place afterwards, and it was also due to trauma, so I think she had some tears as well. So finding out a little bit about her, I hope you can hear me, it's a bit noisy here. She actually had fibroids. So fibroids is kind of another risk factor for bleeding after birth. So we had to ensure that we put precautions in place just in case that was to happen as well, and just speak to her about like the plan of care, but I'll get to that afterwards. So this lady was also GBS positive, and that is a bacteria in the vagina, and once a lady is GBS positive, they actually have to have antibiotics in labor just to protect the baby as well. So she was also in need of antibiotics, and she was on the epidural when we came onto our shift. So with the epidural, there's a lot of things that need to be done. Like you need to check the woman's pain level to check that it's actually working. You need to also check the block level. So we use a cold spray and spray it on the skin from her arm where it should feel cold, and then her abdomen, her leg, and we see how far the epidural goes. Where she doesn't feel the cold or where she feels less of the cold is an indicator to us where the epidural is effective, where she can actually feel contractions or any pain. She also had a scan at 36 weeks, and on the scan the baby's weight was 3 point something kilograms, but it was like on the high end, so we knew that baby was quite big. And at this point she was like 41 weeks, and that's why she was induced as well. She was induced due to the gestation, apparently her age too, but I don't know if you can be induced because of your age, so let me not say that, but induced due to the gestation of the baby, which was 41 weeks. So immediately after handover, I'm trying to do things with more confidence, and I need to do my assessments and get something signed off. So I created the plan of care, and then I asked the midwife, would you suggest that the plan of care be this? And she agreed with me. And it was literally just to do the epidural checks that I just told you about. Also to just ensure that she's hydrating. She can't really mobilize because she can't feel her legs, so mobilization was on it, hydration was on it. Her observations too, the epidural, you need to be checking her blood pressure hourly, because it can affect blood pressure as well. So just to make sure we're doing her observation. She had a catheter as well due to the epidural, so make sure we're emptying the catheter, making sure that it's draining. How much is it draining? How much is she drinking? That sort of thing. And also just the plan of care in regards to what had happened previously as well. So just being cautious. So speaking to her about the birth of the placenta. So active 3rd stage, which was what we went for, which we discussed with her and she consented to, which is an injection into the thigh of synthometrin or syntocinon. And this injection is given to help the uterus contract and expel the placenta. And the last part of my plan was, upon her being fully dilated, because at this point she was 6 centimeters, we would give her 2 hours for baby to descend, just because she's got the epidural, which means she can't feel and she can't be mobilizing or as upright and stuff for the descent of baby. The other thing about this lady was that she had continuous tachographic monitoring because of the epidural and because she was induced and many reasons, but she had the monitoring happening. But she also had a stand clip in place. So this is just a clip that's put onto the baby's head. It goes under the baby's skin. It gives a reading of an ECG trace, and it pays attention to the ST part of a ECG trace. So an ECG, if you remember, I remember from secondary school. Guys, shush. Just making too much noise. Yeah, it has a PQRST wave and the ST part of the wave, if you can imagine it in your head. If you can't, sorry. the ST part of the wave is what the ECG trace tells us more of. So upon looking at her ECG, it looked a bit abnormal. There were events that had come up, and the events that came up were called biphasic events, which I learned are indicators of baby moving a lot, but it's also indicators of infection. So basically, when you see these things come up on the trace, you look at the last 20 minutes of the trace, whether it was normal or not. Now, one thing I learned from the midwife was that she will always classify the CTG trace as abnormal if there are abnormal features, but then she will justify in saying, yeah, it's abnormal, but I can actually see normal features as well, and there's no evidence of hypoxia as well. So she justifies and uses rationale for everything, which is really good. So yeah, essentially we went to introduce ourselves to the woman, made sure that she's comfortable, she's living life. She had her candle, she had her music playing, she was creating vibes, she had aromatherapy? She had like oils and stuff, and yeah, she was living life, she was enjoying. So we spoke to her about the plan of care. I conducted her observations. I emptied her catheter, which is the urine bag, and then we left her to have some privacy, coming in here and there as well to make sure she's getting her one-to-one care at the same time. At the same time, checking the CTG monitoring from outside and inside as well. And it soon became time for us to give her an examination because she had had one 4 hours prior, just to assess her progress. With the examination, she actually just wanted the midwife to do it, not me to do it, just because, like, why is she having it done twice kind of thing? And I kind of get where she's coming from. So that was all cool. The midwife done it, but she couldn't actually confirm what position baby was in because baby was very high. She said very high. But the woman was fully dilated. She was 10 centimeters. Another thing that happened with the examination was the catheter had actually dropped down to the point that the midwife could feel the balloon when she was examining. So she took it out, and I think we ended up putting a urometer in, just because I'm going to look for the name of this thing. It is hematuria. I learned that today. But it's basically the urine is appearing much like blood, and it can be an indicator of infection. So we just put the urometer in to have more precise measurements of the output of urine. So that is hematuria. Hematuria, yeah. As I said before, we gave this lady 2 hours of passive descent, so 2 hours for baby to descend down into the birth canal, and basically we got her into the throne position. So this is where she's sitting on the bed, but we've got the bed up, and then her legs also down to make it more into a chair kind of position, just so baby can move with gravity. And this 2 hours went by super fast. So after that 2 hours went, we came back in. The doctor came in, the doctor conducted an examination, and she found that the head was actually still quite high, but it was at -2. So spines is where the ischial spines are on the pelvis, and then it's so difficult to explain without a pelvis, but yeah, baby was high, but further down from the ischial spines of the pelvis. So we commenced pushing, and yeah, I was kind of coaching her through the pushing, speaking to her, encouraging her to keep going as much as she can. And basically I was looking at external signs. So as she had the stand clip in, there's a lead that's in the vagina. So I'm looking at the lead to see if more of it is coming out. And with her pushing, I was seeing more of it coming out, indicating that she's pushing baby down. But then I'd see quite a bit of it go back up, which is yeah, that happens. Like, you push, baby comes down, baby goes back up afterwards. So what we did as well was we tried different positions. So she was on her side, then she was on all fours, then she was on her back. But there was a point in time where we started to see decelerations, and at that point in time we got her back onto. So the decelerations we saw initially were very normal. They were recovering back to baseline quickly, and it was kind of indicating to us as well that baby is moving down. But then there was one prolonged decel. It was quite long, like, when time just stops, innit? So like, we got her onto her back straight away, and we did some guided pushing, and then it went back to baseline as well. We did some guided pushing with her as well, which is when you have your fingers in the vagina and then also you get her to push against your fingers, and that helps when a woman has the epidural as well, so they can feel that pressure and stuff, and they know where they're pushing into. This was meant to be for an hour. She actually had an hour and a half, and then the doctor came in, done another examination, and found that baby was still in the same place. So what was recommended was to go to theatre and to see what they can do. So by the time they'll get to theatre, they'll conduct another examination and see if baby is low enough that they can do forceps, or if they would have to do a cesarean section as well, because there was deceleration starting to take place as well. At that point in time, the heart rate was fine, but yeah, it had been a while, and it was actually also almost 24 hours after her waters were broken. But yeah, when you go to theatre, you have to sign documentation and stuff. So they brought the paperwork and she did it. Still, she was contracting and pushing and trying, but then she sounded like she was giving up. She was like, I should have just gone for a cesarean section anyway. Why did I even try? And I just gave her some encouragement. I was speaking to her about how far she's come. Like, she's done well. And even with going to theatre anyway, it is her doing the pushing, doing the work. So she's doing well. And she got up to 10 centimeters. That's amazing. So we have to wear scrubs, as you saw me in the previous clip. Probably I was wearing my scrubs in it before we went in. So yeah, got her onto the theatre bed and everything, and basically for the duration of the time was in theatre that the forceps birth was happening, I was actually scribing, because what the midwife was doing was checking the monitor, which I can do of course, and making sure the fetal heart rate is fine, but she was palpating the contractions, and I'm not gonna lie, this simple thing of palpating contractions is not my strongest point. They say put your hand on mum's tummy, you should feel the contractions, you should feel the tummy going harder and releasing. But obviously people have varied contractions and stuff, unless they're strong, I cannot feel it. I can't. But it comes with practice, the midwife said, and she asked me what I'd rather do. And I told her, I didn't say that I don't want to do it, but I told her I'm not good at feet, I can't really feel the contractions. And I like to seize opportunities to learn and improve. But just in this opportunity, with all that the woman's been through and stuff, and because the doctors are literally going to be counting on the contractions, and she's going to be counting on the contractions for her to push, I need to be able to feel it. I said she should do it, and I'll do the scribing. So I was writing down when everything was happening, basically for our documentation. But also it gave me a good viewpoint of the whole room, so I saw everybody's roles in theatre and what everybody was doing. But yeah, forceps was applied with 2 pulls. The baby was out, head was out first, and the body came out. I think 2 or so minutes later, they showed mum baby, stimulated baby. We couldn't really hear a cry or much noise, and baby was actually quite blue. So we got baby to the resuscitator. The ped was there, the baby doctor, and yeah, more stimulation, and then we heard a cry eventually. Bouncing baby, and you will never guess the weight, 4.6 kilograms. And I think that's why baby was up there. Like, it was difficult, maybe a bit more difficult for baby to come down with the position that the baby was in, because baby was also transverse, needed baby to turn because they had done a scan. The position and how big the baby was, like, it was quite big. Like, even I measured the length and head circumference. The head circumference was big as well, so yeah. But in the end, all was well with mum and baby. I just conducted observations for baby every 2 hours because of the group B strep, and also because by the time baby was born, it was more than 24 hours. It was literally 24 hours and 3 minutes, but I still have to do it. And then with mum, she actually had a major obstetric hemorrhage, and she bled again for 2 litres of blood. And she had 40 units so she had 10 international units of syntocinon. She had 40 units of syntocinon, and she had tranexamic acid in theatre to help with the bleeding. But yeah, for mum, we went to the high dependency unit in the end. No, we didn't. We actually stayed on the ward, but she was meant to be in the high dependency unit, so it was treating her like a high dependency person. We're doing hourly obs, checking the urometer, checking the so how much her urine output was and input was. She was on fluids as well. She still had the Synto in as well, and also checking her pads.